Hello, my name is Bryland Pence, and for my first case presentation, I will be doing it on celiac disease. The typical patient presentation will look something like this. A 30-year-old woman presents to her physician with previous history of anemia and unintended weight loss. She presents with the feeling of being bloated and is fatigued throughout the day. In addition, she states she has regular diarrhea and feels constipated on a daily basis. The etiology of celiac disease is still pretty unknown just because it's a fairly new disease. What we do know is that antibodies are produced when wheat protein is identified in the body. The first cause of how celiac disease occurs is through genetics. Another cause could be gastrointestinal bacteria. In addition, sometimes when the body overreacts to the consumption of gluten, the villi that are lined in the small intestine become affected, and we'll discuss that later in the pathophysiology section of this PowerPoint. It is also known that celiac disease can become active in the body after surgery, pregnancy, childbirth, an extreme viral infection, and physical or emotional stress. Celiac disease is becoming more common in today's society. There are currently 3 million cases nationwide. Specifically, 1 in 133 healthy people will be diagnosed. 1 in 56 people who have related symptoms, such as anemia and osteoporosis, will be diagnosed. 1 in 22 people will be diagnosed with celiac disease who have primary relatives who suffer from the disease, such as parents or siblings. The morbidity rates are low compared to the number of people diagnosed with it. In addition, celiac disease is an autoimmune disease causing related diseases, as mentioned before, to attack the body, causing death. Most of the deaths are not primarily caused by celiac disease. This is the celiac iceberg, and it's a representation of celiac disease today. As you can see, few cases are symptomatic celiac disease with damage to the mucosal lining. More than 1/3 of the cases are silent celiac diseases, meaning there's no symptoms present, but there is damage to the mucosal lining. The latent celiac disease section represents cases with a positive test for celiac disease. However, there is no damage to the mucosal lining. Risk factors. The biggest risk factor for having celiac disease is having a family member with celiac disease. As mentioned before, your chances of obtaining celiac disease increases hugely if you have a parent or a sibling who has previously been diagnosed with celiac disease. In addition, having type 1 diabetes, Down syndrome, any autoimmune disease, and Addison's disease will increase that chance. Another risk factor is when gluten was introduced to the person's gastrointestinal tract will largely affect celiac disease. Specifically in children, 50% of affected children onset occurs by 18 months of age. It's common that symptoms will present later in life as more gluten is introduced into the system. So the earlier that gluten was introduced into the system, the more likely you are to obtain celiac disease later down the road. It is also known that the more gluten you eat, the higher the chance of you getting celiac disease is. The pathophysiology. So celiac disease is unique from other autoimmune diseases in that there is a clearly identified environmental trigger, and that environmental trigger is gluten. It's a dominant HLA contribution required for a disease to occur. In addition, antibodies against TG are detectable in over 95% of individuals with celiac disease. It's very common that in autoimmune diseases, there is no environmental trigger. It is something where your body attacks itself, and so with celiac disease, it's very unique because there is a trigger point. Gluten is the cause of celiac disease. So this picture kind of represents the responses that are taking place in your body when you have celiac disease. And so the gliadin ingestion results in activation of gliadin reactive T cells in the intestine. So these are celiac T cells that are hypothesized to provide immunologic help to B cells to produce TG antibodies in addition to promoting the favorable cytokine milieu to help drive the celiac disease process. The gliadin ingestion is also directly toxic to the enterocytes. So this results in a release of the IL-15 and an upregulation of this MICA that you see at the bottom of the screen. On this release happens on the enterocyte surface. So infiltrating the intraepithelial lymphocytes also differentiate in the process of IL-15 into the lymphocyte activated killer cells that are cytolytic to the enterocytes through the interaction between this Mica cell and the NKG2D that you see right above the gliadin peptide at the bottom of the screen. So this is an example of a healthy and normal microvilli. This is something that we want to see in all patients, and this isn't present in someone that has celiac disease. So as you can see, the ratio of villus height to secretion depth is approximately 5-1. And this allows for total absorption of nutrients, including gluten, in the diet. So these are all examples of villi in someone who has celiac disease. So this top picture, there are in excess of 25 lymphocytes per 100 epithelial cells, and the lymphocytes are almost exclusively T cells. This second photo that's found in the middle is a representation of partial villus atrophy with a villus height to secretion depth ratio of 1-1. And remember, in a normal cell, we're looking for that to be about 5-1. And then in the bottom photo, this represents subtotal villus atrophy, where the villi are apparent and they're there, but they're very broad and they're really stubby. And if you remember the normal villi on the previous slide, they were a lot longer and there was a lot of space between them, and that's not what we're seeing here in this bottom photo. So these are all examples of villi inside of someone who has celiac disease. This is kind of a recap of what we saw in the past two slides. Sometimes it's hard to see it on cells, but this kind of exaggerates it. So on the left is the normal villi. You can see that those villi are really long. They're kind of spaced out. And then on the right is the damaged villi. You can see they're flat. They're really close together. And on the right, you can tell that would not absorb as many. It just wouldn't absorb anything compared to the villi that are on the left. The symptoms. So the destruction of mucosal cells causes inflammation, and water and electrolytes are secreted, then leading to the patient to have watery diarrhea. Potassium loss leads to muscle weakness. Unabsorbed fatty acids combine with calcium, and secondary hypoparathyroidism increases phosphorus excretion, which results in bone reabsorption. And fat malabsorption in the jejunum is the major cause of steatorrhea, also known as fatty stools. Vitamin K malabsorption leads to hypothrombinemia. In 1/3 of cases, iron and folic acid malabsorption is manifested as chylosis, anemia, and smooth red tongue. Vitamin B12 absorption is impaired in those with extensive ideal disease, and folate and iron deficiencies are very common. Diagnosis. In order to diagnose someone with celiac disease, gluten must be present in the diet. So there's two types of patients. The low celiac disease probability patients, that means they do not have someone in their family, such as a parent or a sibling, that has been diagnosed with celiac disease. So in this case, they'll do a serologic test, and if that comes back positive, they'll have to do an upper endoscopy with a biopsy. This biopsy will look at the microvilli like we did earlier in the presentation, and it will compare to see if it's healthy or not healthy. Second type of patient is a high celiac disease probability patient. That means they have a parent or a sibling that has been diagnosed with celiac disease. In this case, both a serologic test and an endoscopic biopsy are done right off the bat. They will also have to follow the algorithm that is on the next page for diagnosis. The serologic test calculates how many antibodies are present when the body contains gluten. So, the serologic test is the reason why gluten has to be present in the diet when testing for celiac disease. So, this is that algorithm that was mentioned before on the previous slide, and it's used for high risk patients. So, that person that has a parent or a sibling that's been diagnosed. And it pretty much just talks about the different steps that they take to diagnose them. I know it's kind of small, but I'll leave this here. Feel free to zoom in and take a look at it. Treatment. So the treatment plan for celiac disease is actually really simple. It's a gluten-free diet. That's it. That means the elimination of wheat, rye, barley, and malt. What this does, removing these foods, allows for the microvilli and the villi to heal and absorb the nutrients that it can in the body. That will relieve the symptoms that are present in the patient and allow for things to kind of reset. Most of the time, it's not reversible. Once you have celiac disease, it's not something that you can just eliminate these foods for a while and then you'll be fine. It is a chronic disease. But yes, that is my presentation on celiac disease. I hope you guys enjoyed. I hope you guys can take something away from it. So thank you for listening.